So today's topic that we will discuss is from the CNS, from the GIT. This is third year. Sorry, I was confused. So third year topic from the GIT, that is antiemetics. Antiemetics are basically the drugs that are used to stop vomiting. Although vomiting is a natural phenomena, it is a reflex that happens in many conditions. It's a general body reflex that indicates many things in the body, but sometimes the exaggerated response of this emesis is harmful for the body. So the conditions where we do not need this vomiting, or which is not good for the body, we use the drugs, and these drugs are basically known as antiemetics. Many clinical conditions are there, like in chemotherapy patients. Most of the drugs, they causes the vomiting which is not required. Before any surgery or during surgery, you do not want emesis, because that can disturb the surgery process, or this something can be also lethal. So anything, anywhere where we need to stop the vomiting, we use the drugs known as antiemetics. So today we will discuss the pharmacology of antiemetics, or the different drugs that are used as antiemetics. Before we discuss the drugs or the names of the drug or their mechanism of action, I would like to give you some background about how emesis happens into the body. Because once you know the mechanism, once you know how this emesis happens, then you can easily understand the mechanism of the drugs, or you can easily understand the chemistry of the drugs. So emesis uh, is basically, you can see the slide, the causes of vomiting or causes of emesis are very important. We say that in our brain there is a specific center present, which is known as also vomiting center. So in our brain, the area of vomiting center is there, and whenever this center is stimulated, and then it produces the emesis. This vomiting center, no matter where it is, you don't have to confuse in it, but there is a vomiting center. It's around medulla oblongata or other way. So, so this vomiting center gets input from four areas. This is important. Four areas from this center receive these impulses or the inputs. So these areas are very important, and the drugs that we will discuss in the subsequent slides or lecture, we will focus on these four areas to stop this signaling to reach to the vomiting center. So once this signaling will be stopped, there will be no emesis. So four areas you remember. The first one and the most important one is the chemoreceptor trigger zone, CTZ, or chemoreceptor trigger zone. This is the area that we will discuss later on where it is located. It's around, it's near about brain, or it's a part of the brain. So chemoreceptor trigger zone is the main area that whenever it stimulates causes a vomiting. Then we have a vestibular system. Our vestibular system is a part of the inner ear. So this the inner ear, any problem in this condition, this also causes a vomiting. Third is the higher cortical centers. So the higher cortical centers, whenever they are stimulated, and we do not locate exact position in that, but whenever we have certain higher cortical center stimulation, it also causes the vomiting. And the last one is outside the brain, or this is in the body, and this is the pharynx or GIT. So local inflammation or any local irritation of the GIT, this can also lead to the vomiting, or the reflex reaction. So in the periphery, we have pharynx or GIT, which are the main important part. Whenever they are stimulated, irritated, they may cause you the vomiting. So four areas you must remember: chemoreceptor trigger zone, vestibular system, inner ear part, higher cortical center CNS, and the pharynx or GIT, or any part of the GIT that may give impulses to this vomiting center, and then it leads to the vomiting. A little more detail of these, because they are important in a sense that you should know what type of receptor these zone contains, because once you know the receptor, the drugs will be easy to understand, because the drug always acts on a specific receptor. So if you have a background of these receptors, you can easily understand how the different drugs work. So chemoreceptor trigger zone is a area of medulla oblongata or area postrema, and that is the one which connects to the vomiting center. The important point is there, which I have highlighted and underlined, is that it is present outside the blood-brain barrier. BBB is blood-brain barrier. This zone is outside the blood-brain area. In drug, there is a significance why we are focusing of this blood-brain area, because the penetration of drug is not easy in the brain, and there is a barrier in the outside the brain, or the covering. This is known as a blood brain barrier. So this is important, because the drugs cannot easily enter into the brain. So this area is outside the blood brain barrier, means the access of the drug is easy. So this is important, because we will discuss later on what is the significance of this outside blood brain. So this area is, remember that it is outside the blood brain barrier. The receptor or CTZ or chemoreceptor trigger zone contains mainly two or three types of receptor. The one is D2 receptor. D2 means dopamine 2 type receptor. Okay. Then we have a 5-HT3 receptor. 5-HT3 is the most important receptor in the vomiting. Okay. Uh, okay. Then we have Tariq. Then we have uh, mm, substance P or okay. Then we have, okay, so I was telling that chemoreceptor trigger zone contain the D2 receptors, the 5-HT3, which is the main receptor of this in the vomiting process. Then we have a substance P or NK1 receptor. This is a neurokinin or it's a pain receptor. Simply, you may remember the pain stimulus can produce emesis. So this is three receptors are there in the chemoreceptor trigger zone. And another point important from this zone is that this chemoreceptor trigger zone is mainly related with chemotherapy induced emesis. So patient of cancer therapy, whenever they produce this emesis, this is the zone which is affected. So you have to apply the drugs in chemotherapy patient to stop the stimulation from this chemoreceptor trigger zone. This is important from the cancer patients or chemotherapy patient. So 2-3 points important area. This is the area of brain in the medulla oblongata outside the blood brain barrier. Receptors are D2 receptor, 5-HT3, and pain receptors. And this is important from the chemotherapy induced emesis. So first part we are discussing the causes of vomiting, and in the causes of vomiting we discuss the first area, chemoreceptor trigger zone. Then we have a vestibular system. I told you it's a part of the internal ear or the inner ear. Important point is that it has two types of receptor. It has a muscarinic type 1 receptor and it's a histamine type 1 receptor. And this area is, along with this vomiting, it is also related with the motion sickness. Motion sickness is one of the condition when the patient feel vomiting while he travels. So any traveling causing vomiting, or the conditions where patient complain that whenever I travel to a vehicle, I I, I feel nausea or vomiting. So this sort of cases, this type of patient, they have the problem with this vestibular system. And again, you have to remember the area, and then you have to remember the type of receptor. It has a muscarinic type receptor and histaminic type of receptor. Third area is higher cortical center. It is not very uh, clearly located where it is, but the different smell, sight, emotional factors, they also produce them. So they may be also related with this higher cortical center. We do not have any specific drug to stop this area. They may come in the causes of the vomiting. The fourth one is important, the peripheral part, which is the GIT, and any local irritation of the GIT causes this. The GIT contains again the predominantly 5-HT3 receptor. So serotonin 5-HT3 is also a serotonin receptor. So serotonin 5-HT3 receptor is important here. 5-HT3, and then we have a substance P receptors. Also, some severe pain may also causes vomiting, like MI, which is known as myocardial infarction, or any sort of stones. They may also cause this sort of problem, like MI or biliary stone. Okay, this is the summary of whatever we have discussed up till now. You can also see in one slide. This is important. In the center, we have a vomiting center. Then we have the area is chemoreceptor trigger zone. This is we discussed. Then we have a vestibular nuclei that I discussed of the internal layer. Then we have a cerebral cortex. Uh, we have, and then we have a pharynx and the GIT. So this is whatever I have described uh, in the causing. I have mentioned the different areas as well as the receptors. Okay, now we come with the summary of whatever. So you can easily understand the neurotransmitter that are involved in this vomiting process are basically the serotonin 5-HT3, the dopamine type 2 D2, histamine H1 receptor, and in the muscarinic receptor is M1 receptor or acetylcholine, and then we have a substance P or neurokinin. So more focus on receptor rather than on neurotransmitter 5-HT3, D2, H1, M1, and neurokinin 1 receptor. Now, this is the part that we come that the drugs that we will discuss today that comes are the drugs that basically stop this receptor action. So we have five or six classes of drug as an antiemetic. Remember, this is the part where your questioning start whenever a examiner comes to you and he asks you, tell me the antiemetic drug. So you comes from this list. So first one are the most important one are the 5-HT3 antagonists. Second is D2 receptor antagonist. Third is H1 antagonist, muscarinic receptor antagonist, NK1 antagonist, and the one is additional there, that is glucocorticoid. It is seen that glucocorticoids are helpful in controlling this process. So we also add this drug in the list of these antiemetics. So five classes mainly, remember, and one is additional, or which is adjuvant therapy, or is something helpful. It is seen that it helps in the controlling of this emesis. So this is the list you can always remember. So now we will go in detail by one, and their details, their mechanism, their different side effects we will discuss. So we start with the 5-HT3 antagonists. The drugs that comes in this category are known as satron groups. We have ondansetron, granisetron, palanosatron, dolasetron. So this satron is a suffix that you must remember. So they are the 5-HT3 antagonists. They are the most potent antiemetic drugs. Remember, in the category of antiemetics, they are the most potent antiemetic drugs. Receptor I have already defined in detail. Whenever 5-HT3 comes in the mind, you should know where this is located. Okay, so they mainly block in chemoreceptor trigger zone. So 5-HT3 blockage in the chemoreceptor trigger zone is the main action, and also in the intestinal uh, vagal afferents or intestinal nerves. So they block chemoreceptor trigger zone as well as this GIT part. Most potent one, and they are present orally as well as parenterally. Uh, uh, Palanosatone is one of the example which is used as IV, and it has a very long duration of action. So different you can discuss in detail. It is written in the book which drug has a specific action, but generally they are present as orally as well as parenterally. Parenteral name you must remember, palanosatone. It has the longest half-life. Sometimes it is asked which one of the 5-HT3 antagonists have the longest half-life. And important from pharmacokinetic point of view is that ondansetron is extensively metabolized. So in the metabolism point of view, ondansetron is extensively metabolized in the GIT. All you have to remember is that 5-HT3 group is the most potent group. It is used as a to control the vomiting in chemoreceptor trigger zone and intestinal vagal afferents. Also, the clinical use of this drug, we say they are the drug of choice in chemotherapy-induced nausea and vomiting. I told you that the cancer patients, whenever they are treated with this chemotherapy, they have a intense feeling of this nausea and vomiting. This is a very common complaint whenever we start giving chemotherapy to the patient. And in that setup, in that patient, in chemotherapy-induced patient, the 5-HT3 antagonists are the drug of choice. Also, they can be given post-radiation in post-operative condition. Okay, so clinical use is chemotherapy, radiation, post-operative. Also, in acute onset, they are important. From side effects point of view, every drug has a side effect. The dolasetron is important from the side effect, and then it disturbs the cardiac function, or it causes a QT prolongation. So dolasetron is important in two sense. Once it is extensively metabolized from the liver, so people having disturbed liver function, they should not be given this drug, and they also have a disturbance with this cardiac function or QT prolongation. Okay, so this is first part, 5-HT3, and remember, very important drugs. Whenever you are asked for the antiemetics, you never miss this type, because this is the most important one. Cetron group, how they are given, what are the names, okay, which one is oral, which one is parenteral, then their clinical use important, and their side effects. Okay, the second group we discussed in the antiemetic is dopamine 2 type receptor antagonists. So dopamine have different types. Dopamine receptor D1, D2, D5, we have a different one. So D2 receptor, which are also important in the psychosis process, antipsychotic, they are also D2 antagonists. They are also important in the vomiting process. So D2 receptor antagonists, and they are the drugs that are usually used for whenever we do not have the known cause of vomiting. Okay, a patient came into the hospital setup, or in any emergency, or any condition which causing vomiting, but you do not know the cause. Okay, like in the chemotherapy, you know that the vomiting is due to chemotherapy induced, so you know the obvious cause. But there are many clinical conditions when the patient come with a vomiting without knowing any cause. So the non-specific causes, the drug of choice is D2 receptor antagonist. The first drug that we give in emergency setup to stop this vomiting is D2 receptor antagonist. So they are used for non-specific causes. They also used for any toxic condition, or any drugs you have taken over drug use, or any toxic uremia, is a renal failure, gastroenteritis. Commonly people having problem with this. You also give this D2 receptor antagonist. Not very commonly used as post-operative radiation, but they are mainly used for toxic condition or non-specific cause. Okay, remember the name of the drug. We have 4 or 5 drugs, but the top 2 are more important. Okay, remember this top 2. The one I showed is metoclopramide and domperidone. They are the more important one. If you remember these 2 drugs, this is fine enough. But if you remember the other, this is good. So 2 drugs, metoclopramide and domperidone, I have categorized them in a different way. Why? Because these 2 drugs are also prokinetic drugs. So they increase the activity of this intestinal action. Metoclopramide and domperidone. Okay, they are the prokinetic. They are D2 receptor antagonists. No doubt about it that they are D2 receptor antagonists. Okay, the rest of the drug you can remember is prochlorperazine, promethazine, and droperidol. They are also the antipsychotic drugs. They are also D2 receptor antagonists, but they are not very important. So 2 drugs you remember always, metoclopramide and domperidone. What is the difference between the 2? This is also important. I have mentioned this in the yellow color. Metoclopramide metoclopramide cross the blood-brain barrier, whereas domperidone do not. Okay, so what is the significance? A drug which cross the blood-brain barrier, it has more side effects, whereas a drug which do not cross the blood-brain barrier, it has less side effects. So the D2 receptor side effects, like we have, I've discussed in the lower part of the slide, the extrapyramidal symptoms or dyskinesia, or the disturbance in the gait or different part. This sort of side effects, which are due to crossing of the blood-brain barrier, like extrapyramidal, this is not seen in domperidone. So domperidone having less side effects because it does not cross the blood-brain barrier. And metoclopramide, although it is good, but it may cause cross the blood-brain barrier, and it may cause this problem like extrapyramidal system, or a problem with this movement disorder. Okay, so this drug is considered the best drug, domperidone, and this is very familiar drug. People mostly using as the over-the-counter drug or OTC, and this is known as motilium. Motilium, you would have been well aware of this drug. This motilium is basically chemically it's a domperidone. Okay, so remember name metoclopramide, domperidone. They are the prokinetic. They also increase the intestinal motility. Then we have antipsychotics like 3 drugs, and their side effects are always whenever you give D2 receptor antagonists, and it belongs to the class of these antipsychotics, then you remember that the patient may complain of extrapyramidal symptom or the movement disorder. The movement is restricted. They have a sluggish movement. This is known as dyskinesia. Okay. Okay, the third class we have after 5-HT3, the D2, and then we have a third class that is a part of we discussed the vestibular system. The vestibular system, or the internal ear, it contains the H1 receptor and M1 receptor. The first class is H1 receptor antagonist, and they are effective, I told you, in the motion sickness. The patient having problem with the traveling in the vomiting during the traveling, they are known as motion sickness. And the H1 receptor antagonists, we have diphenhydramine, meclizine, and cyclizine. Okay, these are the 3 H1 receptor antagonists, because you have a number of drugs in as a H1 receptor. We have discussed in this antihistamine drugs. Okay, so in the number of drugs, the selective drugs for as H1 receptor antagonists are diphenhydramine, meclizine, and cyclizine. They are the drugs choice because they have a less anticholinergic property, and they are more effective in motion sickness. Okay, so just remember 3 names: diphenhydramine, meclizine, and cyclizine, used as a H1 receptor antagonist, and used for motion sickness. Okay, anticholinergic effects are always obviously a side effect because they work through blocking the acetylcholine or anticholinergic effects, or histamine related effects, dry mouth, dilated pupil, urinary retention, all these things. So first drug is H1 receptor antagonist, and the second drug is M1 receptor antagonist. Remember that the drugs we are discussing, H1 and M1, they are part of vestibular system. We're discussing the vestibular system, internal ear, motion sickness. These drugs are applied in that condition. So M1 receptor antagonist drug is hyoscine, scopolamine, very good drug. Hyoscine or scopolamine. This is a very effective drug for the motion sickness, and this drug is given in different pattern, like it is available as oral injection, patches, transdermal patches behind the in ear. They are also applied behind the external ear. So people, okay, they have patches, they are provided with the patches, they apply behind the external ear, because the pathology is in the ear, it's in the internal ear. So local absorption is there, so they can stop this traveling vomiting or any condition vomiting. Okay, hyoscine scopolamine, and this is also a drug that produce anticholinergic atropine, like again the dryness of the mouth and other conditions. So remember, a drug like diphenhydramine, meclizine, cyclizine, and hyoscine for the mental receptor. Fourth one are the pain receptor. There's the neurokinin 1 receptor. So condition of severe pain or other condition they also causes, and in that we have they block the chemical neurotransmitter substance P. The receptor is neurokinin 1 and the chemical receptor is substance P. Two drugs we have, aprepitant and fosaprepitant. Remember, aprepitant is a oral formulation, fosaprepitant is the IV formulation. Okay. Also, one of them is water soluble, one of them is basically lipid soluble. Fosaprepitant is basically water soluble drug. Okay. What are the clinical application? They are used in acute and late onset of chemotherapy. So chemotherapy induced patient, so they are combined with this 5-HT antagonist. So chemotherapy, we use this aprepitant or fosaprepitant to stop the emesis in the chemotherapy induced patients. Drug interaction of these drugs are important. It is seen that aprepitant is decreases or shortens the half-life of the warfarin. So bleeding problem, people having the bleeding disorders, or they should be avoided in that condition. Or they increase this INR or the bleeding tendency. So you have to remember that this is important formula. The last drug in the MS is the glucocorticoid. Glucocorticoids are not seen as a direct inhibitor of this vomiting process, but it is seen that these drugs somehow helps in the process to stop the vomiting. And the steroids are used in many clinical conditions because they reduce the inflammatory process, which is almost a part of most of the disorders. So it is not seen how they work, but it is seen that the steroids or glucocorticoids helpful in controlling this pharmacies. So they are help in chemo-induced vomiting, and it is said that they block prostaglandin synthesis. So this is somehow they control this phenomena. So they are combined with 5-HT3 antagonist and NK1. So they're not the main drug, but they are used along with this therapy. Okay, discussing all the drugs individually, I just made slide to remember you because okay, what sort of drug we discuss. We have categorized the drug in the last. Whenever you have a clinical condition of chemotherapy, remember the drug you use is 5-HT3 antagonist. I have given a summary. Choice of antiemetics depends on etiology. Okay, when you know the etiology, then you choose the drug. For example, in chemotherapy, the main drug is 5-HT3 antagonist, but you may combine NK1, D2 glucocorticoid. They are used as an adjuvant, but main drug for the chemotherapy patient is 5-HT3 antagonist. Whenever patient have motion sickness, it is simple, clear cut. The drug is either M1 antagonist or H1 antagonist. We discussed meclizine, cyclizine, or hyoscine scopolamine. Okay. If this vomiting is due to unknown cause or drug induced, the drug is dopamine 2 receptor antagonist, D2 antagonist. And we have drug like metoclopramide, domperidone, and any antipsychotic. This is known as vomiting. This is why very common in our setup that anyone who says I have a feeling of vomiting, we just say okay, use motilium without knowing the cause, because this is used for the unknown cause. In post-operative condition, you can use dopamine antagonist, 5-HT3, and NK1 antagonist. This is a important point just to summarize where you have to apply the condition. This is a summary of the name of the drug because most of the time students face difficulty in remembering the name. So there is no choice that you do not give the name of the drug. So name of the drugs you have to remember. So 5-HT3 antagonists are satron group, ondansetron, granisetron, palanosatron, dolosetron. And what is important with these drugs? I discussed what is important of dolosetron. If you remember, I told you that this is extensively metabolized by the liver, not given in patient with a GIT problem, and also it causes the cardiac side effect called QT prolongation. So dolutegravir is important from uh, the side effect. Pelanosotone I discussed. Pelano is an IV drug, the IV formulation, and this drug has a longest half-life. So longest half-life is pelanosotone, remember. So these two drugs important from pharmacokinetic point of view. Then we have D2 receptor antagonists, metoclopramide and domperidone. The two drugs are the main drug, and they in the two drugs, domperidone is highlighted because it do not cross the blood-brain barrier. All these white color metoclo, all they crosses the blood-brain barrier, so they have extrapyramidal symptom. The side effect is extrapyramidal system, dyskinesia, movement disorder. But this domperidone do not cross the blood-brain barrier, so this is the most safer drug. Then you have H1 antagonist, diphenhydramine, meclizine, cyclizine. Then you have M1 antagonist. There is one drug, hyoscine or scopolamine. And we have NK1 receptor antagonist, aprepitant and fosaprepitant. What is the difference? Fosaprepitant is water soluble, aprepitant is lipid soluble. And this drug is IV, this drug is oral. So this is the difference you should know about. And finally, we have glucocorticoid, and in where we have a two drug, dexamethasone and methylprednisone. So this is a summary so that you remember the names of the drug, which are really very important. I just give you highlight, and that is probably the last slide. Okay, one part is missing in the topic. We are given antiemetics as well as emetics. Although these drugs are not clinically used now, but emetics are also the drugs that are used to induce vomiting. Up till now, we have discussed the antiemetics, but there are some condition where we use to produce emesis which is important. Which is although they are not nowadays used, or they are not clinically recommended, but one remember only one name: Ipecac syrup. Ipecac syrup is a syrup, or it's a drug that are used to induce vomiting, and this is an inappropriate use. People having problem with a nervous disorder known as bulimia nervosa. This is a disorder where a patient feels that he takes some meal and he feels that he has overeaten, so he tries to vomit out by himself. And in that condition, you use this sort of. So emetics are not commonly used, but remember one name. The main part of the talk is again the antiemetics. Probably this is the last slide. Okay. So anything you want to discuss, you can ask question. We have almost 10 minutes so that we can discuss the different one. जियो वैसे आप कनेक्टेड हैं? हेलो
जी सर, आ रही है आवाज, आपकी आ रही है?
हाँ, बस क्लास खत्म हो गई, कोई क्वेश्चंस हो तो मुझे बता दीजिएगा।
हाँ तो सर वो चैटिंग में करेंगे स्टूडेंट ना, चैट ऑन है इनका,
तो मेरे पास आएगा वो?
जी जी आपके पास आएगा सर।
चैटिंग कहाँ आती है ना?
ये आया सर, पहला आया ना।
अच्छा मैं देखता हूँ। सही, ओके ठीक है। Okay, so we can have some question in 5 or 10 minutes. There's a question that is chemoreceptor trigonosome a part of vomiting center? Again, I told you vomiting center is stimulated by different areas. So chemoreceptor trigonosome is an area basically that gives signals to the vomiting center. So when this area is affected, it gives signals to the vomiting center, and then vomiting starts. So indirectly related it is area. So if you block the impulses to the chemoreceptor trigger zone, you can stop the vomiting. Okay, so you may say a part, or you may say it's an stimulatory center which stimulates the vomiting center. Okay, we Again, say metoclopramide is still used in hospital. Okay, yes, metoclopramide is used in the hospital. The potency of the drug is also important. Sometimes you need a potent drug. Metoclopramide is a good or potent drug because it has an access to the brain, so it can also stop directly to the vomiting center. So sometimes you need a potent drug, so you can use metoclopramide. But uh, obviously, from side effects point of view, we use this domperidone. Okay, there is a question slide which shows all the receptors. Yes, you can have slides. You can have access to the slide, or I can show it again if you. Okay, I go to the slide and I just repeat. Sorry. Okay, I'm trying to get. Uh, okay, I'll show you the slide at the end, which shows all the receptors. Okay, again, uh, what are opioids? How do they reduce emesis? Opioids are not basically the direct inhibitor of this, but since they have receptors or mu receptors, so they can stop vomiting while reducing the pain stimuli. Again, I told you, neurokinin 1 receptor or substance P. So pain sometimes produces the vomiting. So opioids may reduce vomiting indirectly by controlling the pain, but from drug point of view, there is no drug given opioid which is used as antiemetic. But indirectly they control the pain and they may reduce the. Okay. Acha, if there's a question, please repeat. NK1 NK1 antagonists are the drugs that basically controls the release of the substance which is again a pain receptor. So NK1 receptor we have aprepitant and fosaprepitant. Those two drugs are there. So this is I told you. Okay, there's a question. Can you please repeat dolasertan? Dolasertan side effects is QT prolongation or the increase heart problem. QT prolongation is the side effects. Okay, how can we get slides? Always there is a question slides. You can ask for the IT person to provide you, or otherwise you should note down my email address to give you, or anyone who's your class uh, leader who can send me the email, and I can give the slides. Okay, okay. Okay, there's a question that in case of toxicity or toxemia, we should allow the patient to vomit out so that this toxin can produce. Why we have antibiotic? Okay, all no doubt that in toxicology we try to wash out the stomach, but sometimes this exaggerated response of vomiting, it is disturb the patient, and you have this vomiting that may can move to the trachea or anything. So this has to be avoided. Immense vomiting is avoided. Otherwise, we need to clear out this vomiters. There's a word anticipatory emesis. Okay. Uh, okay. Aprepitant shortens the half-life of. Okay. This is a good question that it is saying that aprepitant shortens the half-life of warfarin. Okay. If the half-life of this warfarin will be shortened, so I'm missing this. The half-life INR is increased. Isn't warfarin metabolized easily when there is shortened half-life? No, half-life, uh, actually what we said in the slide, that it basically decreases the half-life of the warfarin. So once warfarin is basically easily reduced, it increases basically the INR value. Okay, so okay, we have only 3 minutes left because I thought there is a next lecture by the 10. So you can have slides. I mean, you can have my email address and you can ask for the slide I can provide. Okay, thank you very much for the session. ठीक है वैस
Okay,
वैस
okay, sir. Allah